I'm one of the nurse transitions specialist nurses for NYAIL, and I'm going to be talking to you today about COPD, which stands for Chronic Obstructive Pulmonary Disease. Can everyone hear me okay? Is my volume all right, Suzanne?
I can hear you, Christine. All the attendees are on mute. Just so everyone knows, if you're an attendee and you have a question, simply type your question in the question box, and I will read the question out for Christine. All right, Christine, why don't you go ahead?
All right, great. So before we get into the first slide, I just want to talk to you a little bit about what the lungs are. The lungs are a pair of breathing organs that are located within our chest, and one of their most important jobs is to remove carbon dioxide from our blood. And carbon dioxide is basically the waste product of metabolism. So their job is to remove the dioxide from the blood and bring oxygen to the blood. There's both a right and left lung. I also feel it's important for you to know what carbon dioxide is, since the main function of the lungs is to remove it. Carbon dioxide is basically a gas, and it's the byproduct of cellular metabolism. It collects in the tissues. Then it's cleared from the tissues by the blood within our veins. Then it's carried by the hemoglobin in our red blood cells to then eventually be removed from the body via our lungs in the exhaled air. So now that we have those two down, I wanted to go into what is chronic obstructive pulmonary disease. COPD is an obstructive lung disease that over time makes it hard to breathe. It's a disease that involves inflammation and thickening of the airways. Also involves destruction of the tissue of the lung where the oxygen is exchanged. Obstruction in COPD basically just means that the flow of air in and out of the lungs is less than it should be. When this does happen, basically it means that less oxygen gets into our body tissues and it becomes harder to get rid of the waste gas carbon dioxide. Eventually, as the disease progresses, it becomes more difficult to remain active due to shortness of breath, which you'll also see abbreviated as SOB. Sometimes referred to as either chronic bronchitis or emphysema. Most people will have symptoms of both conditions, so health professionals prefer to call the disease COPD. Some doctors think that chronic bronchitis may be present even though a person does not have the airway obstruction characteristic of COPD. And your doctor or your clients that you're working with, physicians, can explain their condition and the best way for them to treat it. It's very important to remember that in many cases, COPD can be prevented and treated. The next slide is just a diagram of healthy lungs versus COPD. So in the picture where you see the lungs, underneath the lungs, the area right underneath is the diaphragm, and the area inside the lungs is called or referred to as the pleura, and the bronchi are the inner lines that you can see in the diagram. The picture that shows the healthy is the little bubbles that you see in the healthy slide are called alveoli, and think of it as like the branches or the vines that the alveoli are attached to are known as the bronchioles. And you can see in the picture down below what the diseased lung looks like. So I just wanted to put that in there for you to reference.
So the diseased lungs, Christine, the brown parts here, that's are the alveoli stuck together, or are they clogged with something?
Combination of both. They're stuck together, they're clogged, they're not functioning, and this is creating the extra inflammation and the progression of the COPD. So we're going to go on to the next slide. How serious is COPD? So you're working as transition specialists, you're talking to discharge planners, families, your clients, and you want to know, the big picture. So COPD does happen to be the third leading cause of death in the United States, and it can cause serious long-term disability and early death. At this time, unfortunately, there's no cure for COPD, and more than 11 million people are known to have COPD, and up to 24 million may have the disease without even realizing it. Also, the number of people that are dying from COPD is growing very rapidly. Also of interest, which I found surprising when I saw the statistics, is that the deaths due to COPD are much higher in women than they are in men. And unfortunately, COPD is often not found until the disease is very advanced, because the reason for this is because people are not educated on the early warning signs of the disease. It's easy for people. Yeah, go ahead.
Why is COPD higher in women than in men?
They're studying that and coming up with things, but it's thought that women also tend to ignore the warning signs a lot more than men. We often go on and just sometimes, I don't want to be prejudiced here, but sometimes women just have a tendency to go on and function and ignore things and just persevere. They're still really doing studies on why in women it's much greater.
Okay.
Getting back to how serious is COPD, some people just think that they're short of breath, or they're less able to do things that they're used to, often just blaming it on the excuse, oh, I'm just getting old or out of shape. But it's important to remember that shortness of breath is never normal. The good news is that COPD can be found early, and there's much that can be done to treat and manage the disease, which we'll be going into in a few more slides. The next page just shows some statistics showing the increase of COPD deaths in women, and looking at the population chart and the age group, you see the age group 45 to 64, and then 65 and up. I just thought this would be an interesting graph to put in for you to look at. The next slide, we're going to talk about the causes of COPD. And basically, I know you're not surprised, but smoking is the major cause of COPD. Basically, the poisons in cigarette smoke can weaken your lungs' defense against things such as infections, narrow passageways, also cause swelling in the air tubes and destroy the air sacs. About 80 to 90% of all COPD is caused by cigarette smoking. Getting back to, why women tend to have a higher rate of COPD, one thought is, and it's been talked about, I skipped over this, is that because women live longer, they have a greater exposure to cigarette smoke over their lifetime. So that's one thought. I wanted to go back and clear that up. So anyway, we talked about how the poisons in cigarette smoke can weaken the lungs' defense. And about 80 to 90% of all COPD is caused by cigarette smoking. Going to the next slide. Other causes are air pollution and irritating fumes and dust, especially on the job. Also, a very small number of people have a very rare form of COPD called alpha-1 deficiency, which is related to emphysema. This form of COPD is caused by an inherited lack of protective protein in the blood. But again, this is a very rare. Now, in working with your clients, the following signs and symptoms of COPD may be something that you notice, especially if you know what the diagnoses or the main diagnoses are of the people that you're helping transition. Some of the signs and symptoms include things like a chronic cough, shortness of breath while doing everyday activities. A medical term for this is called dyspnea, which you may see on some of the paperwork of your clients. Other signs and symptoms would include someone who has frequent respiratory infections. You may also see blueness of the lips and the fingernail beds, also referred to as cyanosis. Fatigue, another one. Also, there may be excess mucus production, also referred to as phlegm or sputum. And you may notice wheezing. Many people don't experience COPD until later stages of the disease. If you experience or know anyone with these symptoms or think that you could possibly be at risk for COPD, it's important to contact your doctor as soon as possible or encourage a loved one, family member, or someone you're working with to do so. Next slide. It's really important not to wait for the symptoms to become severe because you're losing valuable treatment time when you do that. And early detection is key, critically key to successful treatment. Also, people who have COPD, acquiring a cold or any other type of respiratory infection can be very serious for them. I'm going to stop here and interject a little something here. You know, every fall we ask everyone to get the flu vaccine and or wear a mask if there's medical contraindications why you can't receive the vaccine. And this is just one example here. A lot of the people that you're working with are compromised in so many different ways. And this is one reason why it's important that if everyone can receive the vaccine, that they do so, along with good hand washing, covering your mouth and so forth when coughing. Anyway, so I just wanted to throw that in there. So how do we diagnose COPD? Next slide. If you're at risk or have symptoms of the disease, sometimes testing is done through spirometry. And you can see a little tiny, I couldn't get it any bigger, but an idea of what it looks like. Basically, it's a simple test that can measure and tell how well someone's lungs are working. To do this, you blow air into a mouthpiece and tubing that's attached to a small machine, which then measures the amount and rate of air that you can blow out. So that is called spirometry. Also, your physician will do a complete health history and health exam, chest x-ray and other tests, such as an arterial blood gas test might be recommended. An arterial blood gas test is also known as an ABG. That basically measures the acidity or the pH and the levels of oxygen and carbon dioxide in the blood from an artery. This test, the ABG, is used to check how well your lungs are able to move oxygen into the blood and remove carbon dioxide from the blood. And again, remember, the removing the carbon dioxide is very important because that's removing the waste products. Any other questions before we go into a few slides on COPD treatment?
If anyone would prefer to ask the question out loud, if you write in the question box that you want to be unmuted, I can unmute people one by one. So are there any questions from people before Christine goes on?
Okay. So we're going to talk about how the treatment for COPD. So basically, if you're a smoker or someone you know or are working with are smokers, quitting will definitely slow the progression of the disease. It's important to take any prescribed medications exactly as your doctor instructs you to do.
What would be a common medication that you would see on someone's medication administration record on their MAR that would indicate they might have COPD?
Okay, one of the things that you might see, number one, is an inhaler. And I'm actually going to be getting into that in a few more slides down the way. So let me start with the inhalers. Inhalers are basically used to open the airways and keep them from swelling. The nebulizer, some of the inhalers can be taken with a nebulizer, and you may see that when you're working with a client. It's a machine that's usually sitting next to a chair or bed where they spend a lot of their time. And basically the nebulizer is a machine that takes and changes the liquid medicine into a very fine mist, which is easier for them to inhale deep into their lungs. If COPD is severe, then oxygen therapy may be used to help with some of the shortness of breath. So oxygen may be needed all day and night or only part of the time. And it's important to understand safety involved around oxygen. Important to you when you're entering a home with a client who has oxygen or in the healthcare setting. Obviously, you see signs all the time that are warning no smoking or open flames in the vicinity of people using oxygen. Another thing that you may see or hear about is something called pulmonary rehabilitation. So we've all heard of physical therapy, physical rehabilitation, occupational, but pulmonary rehabilitation is a program that teaches someone about COPD, how to exercise, how to best manage their disease, and at the same time helps, provides support and counseling. In very rare cases, sometimes surgery may be recommended for people who have very severe COPD. Now, going to some of the other modalities and different therapies, when you think about it, we've all heard about occupational therapy. I think we more commonly hear about physical therapy, but occupational therapy can be extremely helpful in someone who has COPD. Because basically with occupational therapy, they can be taught different methods to, for energy conservation techniques. And this also can include common, simple, durable medical equipment like reachers, for example. So an occupational therapist can be very useful in teaching people who have COPD and many other diseases as well on ways to do things easier, to conserve their energy and so forth, so that they can still participate in activities of daily living, just modified so that it doesn't tax them or overly fatigue them or cause them to have an exacerbation. Also, some people enter things, clinical trials, and basically some people can find relief from their symptoms and improved quality of life with different complementary therapies. Some complementary therapies are things like mindfulness, meditation, massage. Those are a few that come, aromatherapy. Those are a few that come to my mind. And you may also think of some as well. Now we're going to get to the part where we're going to talk about COPD medications. And there's basically a variety of medications that are available to treat the disease. And it's important to remember there's no one best medicine for all. Each person's COPD is different, and it's important for you to take the right medicine, and just as important is taking it at the right time to help someone breathe better, to have fewer flare-ups, and to be able to do more of the things that you or the person you're working with want to. People with COPD often will be on multiple medications, and it can become quite confusing, especially to the elderly, and especially if there's some underlying dementia involved as well, something to keep in mind. But again, the key is the right medicine at the right time. And in the picture down below, you'll see someone with an inhaler. So the types of medicines that are prescribed for people with COPD, there are medications that are known as bronchodilators. They relax the muscles around the airways. There are both short and long-acting bronchodilators, and they're often used together. There's also a classification called beta agonists, and their job is to relax the tightened muscles around the airways. Another category is known as anticholinergics. They stop the muscles around the airways from tightening, clearing away mucus from the lungs. And then we have our anti-inflammatories. Their job is to reduce the swelling and the mucus production inside our airways. And then antibiotics are used to treat infections to avoid the flare-ups. And you know, you'll see all different names. You'll see albuterol and Combivent, Duoneb. Those are examples of short-acting bronchodilators. There's also the corticosteroids that are prescribed. You might see names such as Flovent or Pulmicort, prednisone, for example. There's a whole line, but I think it's more important to know what the medications can do. Again, the ones that can relax the muscles, ones that can keep them from tightening and clear away the mucus from the lungs. Again, to reduce the other med classification, to reduce the swelling and inflammation. And again, finally, the antibiotics used to treat the infections. I put in here again, it's a little bit of a repeat, but vaccinations. With COPD, people are at greater risk for serious complications, so not only us in protecting the people that we work with and for, but it's important for people who have these type of diseases to make sure that if they can receive the influenza and also the pneumonia vaccines. It's a good thing to ask people, did you get your influenza vaccine this year? When was the last time you had your pneumonia vaccine? And that for protection, they should be immunized by their doctor's guidelines. As far as the pneumonia vaccine goes, it's very important to get it at least once, but sometimes a booster shot is recommended for certain individuals. Going along to COPD prevention, it's important to know that there are steps that people can take to protect themselves. Number one, which is as driven over and over again and pointed out, is smoking. Quitting smoking is the most important thing that can be done for someone to live longer and healthier. We all know there's many programs that can help people quit for good. They recommend if you don't smoke, please don't start. To try to avoid and reduce your exposure to secondhand smoke is critical. And to protect yourself against chemicals, dust, and fumes, both at home and in your workplace. And maybe to become active in your community and helping to fight for clean air. Some examples of some of things that people can use to help stop smoking and curb the desire. We've heard of the patches that people can use. There are different gums that can be chewed. Medications. There's one medication known as Wellbutrin, which is a form of an antidepressant, but it was found that it also is very helpful in curbing the desire to smoke. And basically, it's very individualized, and a doctor can help you or an individual that you're working with decide on the best option to do with their lifestyle to give the greatest benefit. So, how can COPD be prevented? Basically, kind of the things that we hear over and over again: good hand washing technique, using hand sanitizers when you don't have access to water and soap, avoiding crowds, especially during the cold and flu season. Again, getting vaccinated against both the flu and pneumonia if indicated, encouraging your family, friends, coworkers, and clients that you may be working with to do so as well. Also, having good oral hygiene can protect you from germs in your mouth, which can then lead to infections. That's one that tends to get overlooked. It's not talked about as much as, washing your hands often and so forth, but oral hygiene is really big. So that is prevention. We're going to go on to protecting your lungs. The lungs are basically different from most of the other organs in your body. And that's because they have delicate tissues and they're directly connected to the outside environment. basically anything that we breathe in can affect our lungs. And because the lungs of people who are living with the disease of COPD are already compromised and at risk, it's important to try to reduce exposure to anything that could make their COPD worse or cause an exacerbation, which is just another word for a flare-up. Both Laura and my hope is with preventing these kind of brief overview webinars is to give you an idea of kind of main disease categories. Just so you'll be able to better understand what people that you're working with are dealing with. And I'm actually going to touch on, I'm having a little bit of a technical difficulty here, but I did want to touch on asthma a little bit, while not directly thought of as anything under the COPD realm. If you'll bear with me, I am going to try to find that slide. Suzanne, is there anything you want to talk about while I'm doing that?
Well, one of the things that Amy pointed out is that if you run into people in the nursing home who are using wedge pillows or who always have the bed elevated or their head elevated in the bed, even when they're sleeping, that might be an indicator of some breathing difficulties.
Right, that's a great point, Amy. You know, just kind of walking into the environment where the person you're working with, you know, sometimes just taking a quick look around the room, you'll see different things that can be clues, and that's a really great point to make, Amy. Anything else, Suzanne? I'm still looking here.
I think that the other kind of clue or thing to think about for individuals who have been in nursing homes is that smoking isn't allowed in nursing homes. And while some people may go outside to smoke, there are other people who are quit smoking for the time that they're in the nursing home, and then as soon as they return home, they want to start smoking again, which, you know, we all very firmly believe in independent living, and that's every person's choice whether to smoke or not. That being said, I think that it's incumbent on us to also at least offer smoking cessation treatment, you know, whether it's the patch or the gum or whatever it might be. Most communities do have smoking cessation programs where you can get that stuff either fairly cheap or free of charge. So just something to keep in mind, that if you're sending somebody home from a nursing home that hasn't been smoking for a long time, so you're kind of just expecting that they won't start again, that as soon as they're back in the community, and everyone around them is smoking, they may want to start smoking again. So you need to be there to offer them.
Yep, great. That is so true, because, you know, it's been their symptoms and they've been being managed in the facility that they're in, and sometimes it can even be a common thing with discharge planning. It can be an oversight where, you know, oops, we're not sending the person home with a prescription for whatever they're using to help them with their smoking cessation. And also, getting back to the programs, New York State is fairly aggressive and proactive, and a lot of the smoking cessation tools, medications and so forth, are available free of charge, and your doctor's office should know where to point someone in the right direction to access those free tools, because the state, obviously, you know, they want to keep everyone happy, and it's healthy, and it's important to have people be able to access, especially the either reduced cost or totally free aid. Anyway, I found my slides on asthma, and again, because this is another, we've been talking about a respiratory issue with COPD, which also has certain things, certain elements of emphysema, and even chronic bronchitis can be thought to be classified under COPD. I felt it was important to just do a few quick slides on what asthma is. That may be something that you even see more often. But basically, asthma is a chronic, which means lifelong disease that can have serious impact on an individual's health. Like COPD, there's no cure for this at the present time, but the good news is it can be managed, allowing one to live and maintain a certain quality of life. With asthma, or while breathing, the air basically passes through our noses and down our throats into our lungs, and inside our lungs are the airways, which we saw on the earlier slides in COPD. These airways are often swollen and inflamed, making them very sensitive to the environment and to triggers. What are triggers? Triggers can be things such as having a cold, the weather, environmental factors such as smoke, dust, chemicals, or even pet dander. Getting back to triggers in the environment, things like high humidity, that can be a trigger. Basically, if someone with asthma breathes in one of the triggers, the insides of their airways produce extra mucus, which then causes them to swell. When this happens, the space that the air uses to move in and out of the lungs narrows significantly, which then causes the muscles surrounding the airways to tighten, making breathing more difficult. This is called an asthma flare-up or an asthma attack. The causes of asthma are unknown. It does tend to run in families and can be inherited. Environmental factors can play a key role. Some people are more likely, allergies. Allergies can be directly related to asthma, and some allergies are more likely to develop than others, triggering asthma. Respiratory infections, which we talked about in COPD, as the lungs develop, certain respiratory infections have been shown to cause inflammation, which damages the lung tissue, impacting long-term lung capacity, lung function. Getting back to the environment again, exposure with allergens, irritants, viral infections, infants and children, especially when their immune system is developing, this can contribute to asthma. Adult onset asthma can also be contributed to irritants and air pollution. Again, things like mold, the high humidity I referenced before, food allergies, especially important for those with any respiratory diagnosis such as asthma, COPD, emphysema, chronic bronchitis, etc. Again, plugging in the need to vaccinate against the flu annually if possible. And again, for those of us working with clients to make sure that we wear a mask during the flu season. And just a touch on that, in September when we have our big conference, Laura and I will have a table set up, and it will be, we encourage you to stop by and talk to us. We'll be, of course, having lots of information about the flu, influenza, precautions. We'll have forms available, and we'll have other things to show you, and want to encourage you to stop by and talk to us. And it's a good reminder with it being so close to the flu season starting, and a good chance for us to remind you, and I'll put an early plug in now, when you do, for those of you who do get your vaccine in the fall, to make sure that you keep a copy of proof of that, whether it's a receipt or whatever. But jumping ahead, but September will be here before we know it. We're going to end with symptoms of asthma. They can be different for different people, very individualized, but there are some of the most common symptoms of asthma are wheezing. You might notice a wheezing sound when you breathe, or someone that you're working with does. Sometimes it may only be evident when they're exercising or have a cold. Another thing that you might notice is frequent coughing. Sometimes it can be more common at night. And they may or may not cough up mucus. You'll hear people refer to, is it a productive cough or a non-productive cough? That basically means, is it productive? Is it producing anything? And the terms that we used before, like phlegm and mucus and sputum and so forth. Shortness of breath, feeling like you can't get enough air into your lungs. This might occur once in a while, or it can occur often. Chest tightness is also another symptom of asthma. The chest might feel tight sometimes, especially during cold weather or exercise. And often this chest tightness, again, experienced during cold weather or exercise, can sometimes be the first sign of a flare-up of the asthma. And if you ever have experienced an asthma attack or know someone, it can be a very frightening experience for them. So it's important to help them remain calm and help them reach for their inhaler or medications. But it's a very overwhelming feeling, and it's hard to describe it. But those of you who have experienced it know what I'm talking about, or those of you who have witnessed it. Anyway, thank you. We're going to go into if anyone has any questions, and I also want you guys to be thinking about, and you can pass this on and suggestions directly to Suzanne if you feel more comfortable with that, or also emailing Laura Bingles and myself if you have any suggestions for further. We do have some topics coming up, but if you have any suggestions for other diseases and so forth that you're running into in the field that you would just like to have more information on, please let us know. If you think they're a little too lengthy, or we're trying to keep them as simple as possible, but if we're not doing a good job and you think we're maybe giving more information than you need to know, again, we just want you to have a better understanding, not certainly to the level of a clinical level, but still be armed with enough information and understanding that can help you and the people you're working with. So please share any of your thoughts surrounding that and any other future topics. So thank you.
All right, if anybody has a question, feel free to write it in the question box. And again, if you'd rather speak out loud, simply write that you'd like me to unmute you, and I can do that. So I don't see any questions here. But I think this was an important topic, and as Christine said, it's one that's increasing, which is a little surprising to me given that the rate of smoking is decreasing, but we may be seeing kind of a cohort effect where people smoked previously and now are getting to an age where the COPD is more prevalent. Is that do you think that might be what's going on, Christine?
Yes. Definitely, and the fact that people are living longer, and as they're getting older, it's becoming more of an issue. And again, with the fact that it's something that tends to be diagnosed more in later life, and again, hitting home with the fact that the reason why one of the reasons why we see this more in women is just simply due to the fact that women generally tend to live longer. So that was an important
Okay, so it looks like we don't have any questions. So with that, we'll conclude this. Thank you very much, Christine. And we will send out to all the attendees, we will send out a copy of this PowerPoint, and it will also be available on the website. So thank you very much, everyone, and we'll have another topic coming up next month. Thank you.
Yeah, bye.